Hello, today we are going to discuss an algorithmic approach to anemias in pregnancy. Here now we have an algorithm. It's pretty large. Of course, it is not possible to read the entire algorithm at this magnification. We will zoom in and see different parts. To start with, when you suspect that a woman is anemic from her clinical examination showing pallor, the first step is to check the woman's hemoglobin. We do a hemogram. If the hemoglobin is less than 10 gram per deciliter, then she has anemia, and then we can use this algorithm. On the other hand, if the hemoglobin is 10 gram per deciliter or more, there is no anemia. Then nothing further need be done as far as this algorithm is concerned. When it is less than 10 gram per deciliter, we check the other parameters of the hemogram. Now, three parameters of the hemogram are important. One, the reticulocyte count or retic count. The second one is the mean corpuscular volume, MCV, and the third one is peripheral smears. We'll start with the reticulocyte count. I hope that is now readable even on a phone. When the reticulocyte count is increased, we recheck the clinical findings of the woman. If she has hemorrhage, then it accounts for the low hemoglobin as well as the increase in retic count. If she has got splenomegaly, then she probably has hypersplenism. One needs confirmatory tests for confirming this diagnosis, but then it is most likely. And if the reticulocyte count is normal, then we go further below in that algorithm. Then we check the free red blood cell protoporphyrin. If it is raised, it is lead poisoning. If it is normal, then the next step is to check serum haptoglobin. If it is low, the subsequent step is to do urinalysis and serum indirect bilirubin. We will come to this part later on. On urinalysis and serum indirect bilirubin, if we find that the woman has got hemosideриnuria and hemoglobinuria, then it is intravascular hemolysis. If she has got indirect bilirubin raised, then it is extravascular hemolysis. If she has got intravascular hemolysis, we need to find out why she's got that. So at that, we check for presence of cystocytes. If these are present, then we check for valvular processes. If a cardiac valvular processes is present, then it is the cause. If she hasn't got any valvular processes, we then check for disseminated intravascular coagulation by doing laboratory tests. If it is present, then the diagnosis is thrombotic thrombocytopenic purpura. If it is absent, then it is hemolytic uremic syndrome. We go back up the algorithm again. If the cystocytes were absent, this is where we bifurcated. So if it is cystocytes are absent, we do a Coombs test. If it is positive, the diagnosis is autoimmune hemolytic anemia. If it is negative, then we do a flow cytometry. A positive result indicates need for another test known as Donat-Landsteiner test, which is for presence of antibodies. If the test is negative, then the diagnosis is Wilson's disease. If the test is positive, then it is paroxysmal cold hemoglobinuria. Flow cytometry results are negative, then the diagnosis is paroxysmal nocturnal hemoglobinuria. This part of the algorithm ends here, so we go back up. We have checked this, we have checked this also. We go up cystocytes, we checked. This part also we have checked. Now we come back to this part where we had checked serum haptoglobin and found it to be low. Then we went down this way. Now if the serum haptoglobin level is normal, then we do a bone marrow examination, and if it shows ringed or abnormal sideroblast, then it is sideroblastic anemia. We go back further up. We have checked free RBC protoporphyrin. We had checked for splenomegaly. Up to here we had seen. Now if the reticulocyte count is normal, then the step goes to where we had done a bone marrow examination, and then subsequent workup is as before. If it is decreased, reticulocyte count is decreased, then we do serum iron studies. Low results indicate iron deficiency anemia. Normal results indicate need for doing hemoglobin electrophoresis for hemoglobinopathies, and you can diagnose by hemoglobin electrophoresis thalassemia, beta thalassemia, when hemoglobin A2 level is high and hemoglobin F level is normal or high. Presence of hemoglobin S indicates a sickle cell disease. If it is normal, it could be anemia of infection. So we have finished this part of the algorithm, which involved looking at the reticulocyte count. We go to the next part of the hemogram assessment based on mean corpuscular volume. First part in this algorithm we had already seen reticulocyte count. This is the second part, and here is the third part, peripheral smear, to which we will come by and by. With mean corpuscular volume assessment, if MCV is low, it is iron deficiency anemia. If it is normal, then it could be due to alcohol, various drugs, liver dysfunction, or hypothyroidism. If mean corpuscular volume is high, then we check for megaloblasts. If megaloblasts are absent, then the diagnosis is again alcohol, drugs, liver, or hypothyroidism. If megaloblasts are present, then we check the actual retic count. If it is more than 2%, the diagnosis is hemolytic anemia. Then we need to find out which type of hemolytic anemia, but then the broad category is hemolytic anemia. If it is 2% or less, then the next step is to check serum B12 level. The level is less than 100 picogram per ml. The diagnosis is B12 deficiency. If it is 100 to 400 picogram per ml, the next step is to check methyl malonic acid, which we will call MMA for putting it in this flow chart, and homocysteine level, which we will call H for the sake of saving space in this algorithm. So we check for methyl malonic acid and homocysteine levels, and this is what we can find. If methyl malonic acid and homocysteine both are raised, then the diagnosis is B12 deficiency. If methyl malonic acid is raised but homocysteine is normal, it is still B12 deficiency. If methyl malonic acid and homocysteine levels are normal, then it's an indication for doing a bone marrow examination. And if methyl malonic acid is normal while homocysteine is raised, the diagnosis is folic acid deficiency. So we finish this part of the algorithm. Now we go to this part where, based on serum B12 levels, if the value is more than 400 picogram per ml, then we check RBC folate level. If the RBC level of folate is low, then it is folic acid deficiency. If it is normal, then it is an indication for bone marrow examination. So we finished with the mean corpuscular volume and then going down below up to here. Now we go to the peripheral smear assessment, pretty big thing. Here we now have the peripheral smear, and it can show various things, starting with hypochromia. Hypochromia indicates that the anemia is due to iron deficiency. We have to find out the cause of this. If there are oval macrocytes and basophilic stippling, then we check serum B12 and folic acid level, and if it is normal, then we do bone marrow examination. If these are low, then we have got megaloblastic anemia. Presence of target cells is an indication for checking the liver function test and the renal function test. If there is macrocytes present, then it is liver disease, and if there are microcytes present, it is thalassemia. If these two are normal, so be it, but they are usually abnormal. If there is microcytosis, then we check serum ferritin levels. Serum ferritin levels are low, it's iron deficiency anemia. If these are normal or high, serum ferritin normal or high, then it could still be acquired or chronic disease. That comes from history. For both of them, the same algorithm. If it's an acquired condition, initially she was normal and now she has got this disease, then it is an anemia of chronic disease. And if it is a chronic disease, long-standing duration, then it is most likely thalassemia. You need confirmatory test for this, but then still, this helps in making a very, very sensitive guess. Going back to our algorithm, we finished hypochromia, oval macrocytes and basophilic stippling, target cells and microcytosis. Our next one is presence of elliptocytes. This is the remaining algorithm. Presence of elliptocytes is elliptocytosis or hovelocytosis. Presence of spherocytes indicates need for doing a direct Coombs test. If it is negative, it is spherocytosis. If it is positive, it is autoimmune hemolytic anemia. If there is presence of autoagglutination in the peripheral smear, the diagnosis is called autoimmune hemolytic anemias. Because the paper could not stretch forever on either side, I have split the algorithm here, and at reduced magnification you can make out this is peripheral smear, and besides these, now there is a line going down here which is actually to be read in continuity with this on your right side. So furthermore, if there is anisocytosis, the diagnosis is hemoglobinopathy. If there are spur cells, it is spur cell anemia. If there are schistocytes, it is a traumatic hemolytic anemia. And this thing continued down. If there is pancytopenia, then we have to do bone marrow examination. This Heinz body we will see a little later. On bone marrow examination, you have a number of findings. A bone marrow examination. It shows aplasia, it is aplastic anemia. If it shows normo or hypocellular picture, it is myelodysplastic syndrome. If it shows myelofibrosis, well, that is the diagnosis, myelofibrosis. And if it shows infiltration by other disease cells, the other disease cells could be metastatic carcinoma, then you need to find out the primary. If it shows lymphoreticular malignancy, you need to treat it appropriately, and it might show even tuberculosis. Going back to the other abnormality, the Heinz bodies. One checks for, and in presence of Heinz bodies, one checks for enzyme defects in red blood cells, and if these are present, the diagnosis is G6PD deficiency, and if there is no enzyme defect in RBCs, it is unstable hemoglobin. We have covered the entire algorithm. Let's look at it from a distance. Yeah, we covered all components. As you must have noticed, the same diagnosis can be reached not only from a single parameter like retic count or mean corpuscular volume or peripheral smear, but these abnormalities, different abnormalities present in more than one parameter also would reach the same diagnosis, giving it additional weightage. And now let us look at some of the abnormalities in the various cells that we have already seen. Hypersegmented neutrophil, now you see these small black arrows, they indicate erythroid hyperplasia. You see this yellow arrow over here, it is a megaloblastic change, and on the arrowheads like this one over here, it shows dysplasia. Hypochromasia, the arrow over here is indicating Heinz body. Here are hypersegmented neutrophils. A picture of microangiopathic hemolytic anemia. You see these cells? These are sickle cells. You see these round cells with very small pale area in the center. Some of them do not have any such pale area. These are spherocytes. These cells with spikes outside, these are acanthocytes. Another slide showing Heinz bodies. These are Howell-Jolly bodies. A picture of iron deficiency anemia. You see that hypochromasia, microcytosis. This basophilic stippling is shown by those black arrows, is characteristic of lead poisoning. These cells, oval ones, these are macroovalocytes. These are the cells which are pointed out are helmet cells. These are seen in macroangiopathic hemolytic anemia. These are megaloblasts. The top cells, these show polychromasia here. Okay, this one is a spherocyte. Black arrows indicate spherocytes. These are Howell Jolly bodies, one here, one here. These are ringed sideroblasts. Ringed sideroblasts. These are cystocytes. Arrows are indicating cystocytes. Here, here. Very good slide showing sickle cells, multiple sickle cells. Spherocytes, very classic picture. Target cells, very classic picture. I'm sure you have seen these slides in your second MBBS pathology, and I'm sure your OBGY examiner will not keep slides at spots, but then you never know. These are teardrop cells. This is a chart which shows various abnormalities in various disease conditions, which is too small print for you to read, and anyway, that is a lot of theory. This shows consequences of hemoglobin level. This is not part of algorithmic approach actually, but since I have the table, you might look at it. When the hemoglobin is 8 to 9 gram per deciliter, the oxygen delivery to tissues can still be maintained. When it is more than 9 gram per deciliter, the woman has no symptoms. When it is 7 to 8 gram per deciliter, she has dyspnea on exertion. 5 to 6 gram per deciliter, there is profound fatigue. 3 to 4 gram per deciliter, she has dyspnea at rest. And 2 gram per deciliter, there is cardiac failure. We don't want to go into treatment because algorithmic method of diagnosis. Does not include treatment. You must have covered treatment of various anemias, and anyway it would be too big a thing to cover treatment of all sorts of anemias in this lecture. So I hope you enjoyed looking at the algorithm. You will feel toxic because unless you are practicing this every day, something like an obstetric hematologist maybe, unless you are doing this every day, it would be humanly impossible to remember such fine details. But then you can always print a chart like this and keep it under the glass on your consulting table, or you could have this chart on a computer and look at it on a screen, whatever way, and then it can be used as a ready reckoner, and then you can reach a diagnosis. I hope you enjoyed this lecture. Bye bye.